So how do we get the answers to the questions that are relying upon much more integrated data than we've ever had in the past? The answer lies to a significant extent in cost accounting, coupled of course with many other aspects of IT. But cost accounting has not been done well in healthcare for many reasons. Today, with better data, at least in comparison to previously, we should be able to do better with accounting for costs and determining the total cost of care as applicable to our setting. Cost accounting in healthcare is defined as a system for recording, analyzing, and allocating cost to the individual services provided to patients, such as medications, procedures, tests, room and board, and so forth. Cost accounting has been difficult with siloed systems, and in particular between separate financial revenue cycle systems and clinical systems. Despite the fact that it is estimated that 96% of hospitals and 85% of office-based physicians have some form of EHR, though many physicians have basic EHRs that are not certified for meaningful use, and an unknown number of physicians are not using or fully using the EHRs of any kind that they have, and the fact that EHRs have improved clinical system interoperability because all clinical data are contributed to an EHR. EHRs are still only designed for documentation and retrieval of information on one patient at a time, not for aggregating data from multiple patients, let alone integrating financial revenue cycle data with clinical data, except for billing information. As a result, many providers do not have cost accounting systems of any kind, and only a few have a very rudimentary one. Today, we are starting to overcome this interoperability issue not by forcing systems to adopt new standards, which, even if agreement could be reached on which standards to adopt, would require a complete, very costly rip and replace program. Rather, this is being accomplished by moving data from the various disparate systems into a data warehouse and/or registry system. These can be in-house or contracted services. Data warehouses tend to be used when massive amounts of data are required for sophisticated analytical processes, and especially where comparisons are to be made across disparate entities anonymously. Registries are systems that focus on certain types of data, such as tumor registries, diabetes registries, implant registries, etc. They may be used by researchers or they may be used in a given provider setting to aggregate information from a particular group of patients, perhaps to notify them of an implant recall, send notices to their diabetic patients when they are due for checkups, or to study variation in treatment of a certain condition. Ultimately, there is hope that HL7 FHIR, previously described as an application programming interface resource that is platform independent, may aid in furthering interoperability such that cost accounting systems could be more viable and EHRs could be the beneficiary of some of the results of such systems at the point of care. Not only have cost accounting systems been difficult to build due to lack of data integration techniques, but they are also challenging to set up. There are several reasons in addition to the lack of data integration to date. One reason that will continue to be challenging if we don't work to gain agreement across all stakeholders on what total cost of healthcare means is that there are many ways to perform cost accounting in healthcare. The list here on this slide identifies the most commonly used methodologies. Standard cost based on charge codes, ratio of cost to charge, relative value unit, cost to charge ratio, largely for diagnostic studies, percent markup, supply cost, activity-based costing, allocating cost to chargeable and non-chargeable activities, and time-driven activity-based costing to identify maximum capacity. While we are not going to go into depth on these, for which you would really need a course on cost accounting in healthcare, the key point is that with this much variation in methodologies, conducting comparisons across provider settings and with health plans is made very difficult. In the past, this may be of less issue because the results were really only used within a given setting for limited purposes. But as integrated delivery systems and centers of excellence and other provider organizational structures are increasing in merger and acquisition mode, the ability to compare cost data is critical. So too is the ability to conduct contract negotiations with a health plan if an apples to apples comparison cannot be made. Enter employers who may want to negotiate with a provider. And there are even more challenges, especially since employers who are in manufacturing or other types of industries where costs of goods or services are very clear, have much less of an appreciation for the complexity of healthcare accounting. As a result of the need for much better cost data in a value-based care environment, a newer approach to healthcare cost accounting is being developed. This is referred to as advanced or contemporary cost accounting. In this methodology, the charge master that we discussed in the first lecture of this unit plays a key role. The charge master must be complete, accurate, and up to date. The formula for this form of cost accounting utilizes charge master data along with the relative value units, RVUs, to essentially merge costs of what would be considered goods in a manufacturing environment with services or the cost of professional health care. RVUs originated in CMS as a system to pay physicians for providing services to Medicare beneficiaries. The RVUs are the result of factoring in the work, the amount of time a service requires, skill level, such as primary care physician versus specialist, mental effort judgment required to perform the service, and a stress factor. These four factors can obviously be interpreted in many ways within any given specialty, so there is a very formal process to obtain physician input into the factors and to maintain their validity over time. In the fee-for-service environment, physicians are reimbursed under Medicare based on the RVU factor, reflecting that work as described already, practice expense, and malpractice expense for each CPT code reported on a claim. This is changing as Medicare pursues value-based care, with the RVU for the CPT code being only one of the adjustment factors in the new MIPS payment scheme. In the advanced cost accounting methodology, the concept of the RVU is also being extended to other staff, where, for example, licensed practical nurses are distinguished from baccalaureate nurses who are distinguished from advanced practice nurses, physical therapy technicians distinguished from physical therapists, etc. Variations in living and business costs across the country can easily translate to these other professions. While the charge master and RVUs for all professionals are the key factors in the advanced cost accounting methodology, other factors are also considered to arrive at an accurate total cost. These include actual direct costs, time-based values, industry-level RVUs, and non-chargeable activities.